Okay. Hello, I'm Howard, and today I'm going to be presenting a case study of hamstring rupture rehabilitation. So for introduction, among the acute musculoskeletal injuries during sports activity at high school, collegiate, and professional levels, hamstring strain takes up a large percentage. Over 10 years span among the players of NFL teams, the occurrence of hamstring strain or injury was only secondary to knee sprains. Although acute third-degree injury or hamstring strain happen infrequently, they occur both at well-trained athletes and middle-aged or middle-trained patients. So for my athlete's case here, he's a football kicker. During the last quarter of the football match, he decided to go on for a field goal for an extra long-range attempt. He hasn't kicked in a formal match for months due to a previous hamstring strain, and he did not kick earlier in that match. So this is what happened at the time. So after he kicked the football, with his leg was still in the air swinging, he heard a pop and felt posterior side pain. He reported pain sensation of being shot in the posterior side and also subsequent difficulty ambulating. On-site examination, what we found out is he had localized tenderness and swelling, and also with a distal retraction of the involved muscle belly, weakness and visible defects with active and active assisted knee flexion in the prone position confirmed that the discontinuity of hamstring and the muscle complex. On site, there were no sciatic pain or neurological symptoms was found at the time, and massive swelling and ecchymosis was developed after several days. So here's two pictures showing the ecchymosis and local swelling, and also here we can see the defect of muscle belly, the rupture. And as for anatomy and biotech, here's just a quick review. So hamstring acts on both hip and knee joints. Semitendinosus, part of it, extend the hip, flex the knee, and immediately rotate the leg. And so does semimembranosus, does the same job. And then for basic femoris, the basic job is to extend the hip. Etiology and pathophysiology. So hamstring strain, especially for distal rupture at the insertion point, there's generally two modes of injury that happens. The first one is the occurrence of hamstring strain injuries during high-speed running. It's generally believed to be occur during the minimal terminal swing phase of the gait cycle. During the second half of swing, the hamstring are active, lengthening, and absorbing energy from the decelerating limb in preparation for the full contact with the ground. The greatest musculotendon stretch is incurred by the bicep femoris, which contributes to its tendency to be more often injured than the other two muscles. And here's a graph showing the general cycle of when we plant that foot in the ground during high-speed running. The bicep femoris is at its maximal stretch at its weakest point. And the other mode of injury is during dancing and kicking. This hamstring injuries occurs during activities such as dancing or kicking that can occur either slow or fast movement that involves simultaneous hip flexion and knee extension. This kind of movement place hamstring in a position of extreme stretch, with the injuries most commonly present in the semimembranosus and its proximal free tendon, which is here as illustrated. And also, as opposed to the intramuscular tendon, which is involved in high-speed running. And as for risk factors for hamstring injuries, there are non-modifiable risk factors and modifiable risk factors. So for non-modifiable risk factors, they're generally age of the individual and their previous history of hamstring strain. And for modifiable risk factors, we can see there's hamstring weakness, fatigue, lack of flexibility, muscle imbalance, limited quad flexibility, and strength and coordination deficits of the trunk and the pelvic muscles. So during the injury, for our onset assessment, we find out for manual muscle testing, the hamstring grade was 3. And then for active and passive range of motion of knee flexion in 3 hip positions, which are performed at hip rotation at 0 degree, 45 internal and 45 external rotation. And the athlete report, there's more pain produced in the 45-degree internal rotation during the test. And as for the rest of the special tests of the knee, we ruled out ligament, patellar, and meniscus injury. All the findings were negative. And resistive range of motion was not performed due to excessive pain. So the immediate care, the injured area was iced for 20 minutes with ice bag for a 20 minutes break interval for the first 3 hours after the injury, then 20 minutes every hour throughout the day when that happened. And for NSAIDs, he took ibuprofen, and according to the dosage, every 6 hours and 3 times a day. After that, he was referred to a doctor for further examination immediately. Hamstring strain injuries are commonly graded as grade 1, grade 2, and grade 3, as we know. And grade 3 is the most severe, which is rupture. And it is what we are going to focus mainly today. And this is a MRI scan image of the injured athlete when he ruptured his proximal tendon. And that is taken from a T2 chronal plane and another from axial plane. And we can see the rupture is clearly indicated here. As for plan and goal, our first goal is to be return to a prior level of performance with minimal risk and injury occurrence, and try to get them handle the high eccentric loading upon return to play, which is a major injury mechanism for hamstring. And musculoskeletal deficit directly resulting from the injury. That's what we commonly address, would be swelling, pain, weakness, loss of range of motion, and gait problem. And also, at the end, we will address those modifiable risk factors mentioned above to prevent injury or decrease the incidence of reoccurrence. And coming back, when the hamstring injury is suspected based on the injury, it is pretty important for us to identify whether the intramuscular tendon or the aponeurosis is injured or against the proximal free tendon. So basically, we're trying to identify either bicep femoris or summit membranosus is injured in this situation. And the purpose of physical exam here is basically to determine the location and the severity of the injury. And we can use X-ray and MRI for our physical examination. X-ray is basically to rule out a avulsion fracture, but it doesn't do much of a good job in determining the exact location and severity of the job of the injury. And MRI, as we see here, can clearly show us how much soft tissue damage has been done and what's the severity of it. And also here we want to address sciatic nerve test. Because during the injury, the sciatic nerve is commonly involved, and if the sciatic nerve is injured during injury, it would prolong the rehabilitation process, and the development of scar tissue on the sciatic nerve would impede the motion control and the gait problem that would develop from it. And in this athlete's case, according to the MRI, the doctor, the diagnosis of a complete rupture of free tendon of semimembranosus by doctor was determined, and surgical repair was arranged for a better recovery. Because during for the comparison of surgical and non-surgical repairment, the surgical repairment showed a better and more efficient return to play effect on the injury. And for those who treated non-operatively, they all reported gait control problem, knee control problem, and muscle weakness. Immediately after surgery. So immediately after surgery, the athlete was fitted with hip orthosis, and the device is used to restrict hip flexion from 15 to 30 degrees. And after that, he will ambulate on crutches, toe touching weight bearing. Post-operative rehabilitation. So for the first phase, right after the injury, we want to start toe touching weight bearing for the first 10 to 15 days with advancement to 25% of the weight bearing for the next 3 weeks. Then we can gradually start passive range of motion of the knee and hip that begins at week 2. Then at week 4, we can start gentle active range of motion. Then after that, by week 6, the brace is discontinued. Then for the second phase of rehabilitation, full weight bearing starts at week 5, and normal gait training also starts at that time. Passive range of motion and active range of motion are progressed with isotonic exercises. Core pelvic strength training and closed chain exercises are incorporated too. At the time of eighth week after surgery, isotonic strength training is progressed and dynamic training is advanced. And isometric strength evaluation at 60 degrees of knee flexion is performed at 10 weeks for further comparison of the recovery. The final phase of rehabilitation, initiation of dry land jogging after 10 weeks, and a full isokinetic evaluation is performed at 60, 120, and 180 degrees per second, and compared to the non-operative side for recovery process. Therefore, more specific activities can start when their isokinetic testing is 80% compared to the anesthetic side. Return to play criteria. So for return to play criteria, we want them to have full range of motion, full strength, and functional ability that can perform without complaints of pain or stiffness. And as for specific criteria, we can see for strength, we want them to complete 4 consecutive pain-free repetition of maximal effort manual testing, and the knee flexion angle at which peak concentric knee flexion torques occur should be similar between the limbs. And in conclusion, awareness throughout the examination and thorough examination is critical, because for most of the hamstring injuries, they are either under-evaluated or their diagnosis was delayed, and that would result in scar tissue formation over the muscle and the nerve that delays the rehabilitation process and time. And then gait and control problems would appear if not properly rehabilitated, like I mentioned before. And preventive strengthening and flexibility training is critical to prevent recurrence and further injury. Thank you.
Where was the rupture and how was it surgically corrected?
The rupture for the athlete happened on the free tendon of semimembranosus. and they use a surgical technique to correct it, but I didn't include that in my presentation.
What was the actual timeline from return to injury to full return to play?
The actual, from the time of injury until they can re-engage in a sports-specific activity or return play is about 6 to 9 months according to study.
And what was it in your case?
I didn't include in my case.
You mentioned that one of the primary mechanisms for hamstring injuries was follow-through injuries with kicking, and I think dancing was one example.
Mm-hmm.
Is that due to overstretch or eccentric overload?
I think it's both, because during the kicking motion, the muscle is stretched as almost as its maximum strength, maximum length, and also the eccentric load that comes with it have a deceleration part of the calf.
Anyone else, or just me?
Yeah, Mark.
How's the, can you go over how the sciatic nerve is involved in the injury again?
Yeah, so for a hamstring, for the acute rupture, there's two types. There will be either acute or chronic. And for acute, the situation is pretty clear. Once you get it repaired, not too much scar tissue will develop on the sciatic nerve. And for the chronic one, if you operatively repair it after 4 months or longer, the scar tissue will develop, most likely develop on the sciatic nerve, which cause some neurolysis and compression of the nerve. And also the peroneal branch of the nerve will get affected by the